Hello and welcome to the webinar. My name is Megan Nicholson and I'm the Director of Marketing at wellbe.me. We're happy you've decided to join us today for 5 clinician-patient communication gaps compromising your hospital's outcomes, quality, safety, and patient experiences. A few housekeeping details before we get started. This webinar will be recorded and you should receive a link to the recording and slides tomorrow by email. Please feel free to share this webinar with colleagues who could not attend today. A question and answer session will immediately follow the presentation. If you have a question for our speaker, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by wellbe.me. The wellbe.me patient guidance system helps fill in clinician-patient communication gaps and reinforce important messages through the entire patient journey of an acute care episode. Smart checklists are delivered just in time as patients progress through their care plans. The information is always there for reference when needed in case preparation or follow-up instructions are forgotten. To request a free demonstration, respond to the poll on your screen at the end of today's webinar. Now I'd like to introduce our speaker for today. Stephen Wilkins is a thought leader, researcher, entrepreneur, and blogger at Mind the Gap, whose areas of expertise include patient engagement and physician-patient communications. He has over 20-plus years experience as a hospital marketing executive, consumer health behavior, and patient-centered communications expertise. Steve, I'm going to hand it to you, and you can take it away.
Great. Thank you, Megan, and thank you to wellbe.me.com. I appreciate the opportunity to share this information with you today, and let's go ahead and get started. Well, let's see, how do we progress off of slide 1 here?
Just click right on the slide and then you should be able to.
Okay, there we go.
Here you go.
Yeah, okay. Well, you know, Megan already gave you the introduction on who I am. I guess I'd underscore a couple of things. The first one I added to this was that I'm a human being, because oftentimes when we talk about patient, consumer, we oftentimes get hung up on the nomenclature of what we are. But first and foremost, throughout this whole conversation today, we're all people talking and dealing with other people, because healthcare at its very basic is a social phenomenon. It's not a technology-driven phenomenon. It's not a provider-driven phenomenon or a patient-driven. It's what occurs between human beings in probably the most personal and most intensive interactions, our healthcare and keeping alive in some cases. So I underscore that. I underscore 25 years of being a hospital administrator in the marketing business development area, and I guess I would progress from there also to being a patient. In the past year, I probably in the past 2 years, I've had 6 major surgeries on both eyes. I've had 6 detached retinas that have required 6 complete, what they call vitrectomies, which involve going in and taking everything out of the eyeball, kind of relasering everything back down and putting it all back together again. And in that process, I've also been the caregiver for my wife, who, for some of you who may know my work, is a 10-year lung cancer survivor. And that has been an incredible experience. It was actually what started me out on this journey of physician-patient communications. And so all of those are by way of telling you my story. As a human being, we all bring stories to our healthcare. But that the takeaway from these stories is that the simplest and most cost-effective way of fixing much of what is wrong with healthcare today, much of what we read about, what we talk about, is that if we were able to get doctors, patients, clinicians and patients to talk to each other using patient-centered communication skills, we'd be a long way down the road to fixing much of what's wrong with healthcare today. So that's my personal story. That's my personal belief. Let's jump right into the topic. So why is patient-clinician communication so important? Well, it's important for a variety of reasons. Number one, it's how patients are diagnosed. There's a great quote by Sir William Osler, who is credited as being the founder of Western medicine, who says that if you listen to patients, they'll tell you what is wrong. And that going back to the turn of the century, the 20th century, that in fact we didn't have technology like we do today. What it was two people sitting at the bedside talking, often in the patient's home, where the physician was the clinician, and the physician basically asked the patient what they thought was wrong. And they spent a lot of time talking and touching the patient, exploring the patient's chest by osculating to hear for chest sounds, and thumping on the chest and the rest of in the abdomen and whatnot. So talk and touch were very important parts of that, but the patient oftentimes was the one that told the clinician what was wrong. Communications is important because it's also how treatment and care plans are arrived at. And finally, it's also therapeutic, that there's a tremendous amount of research that doesn't get a lot of talk in the literature that communications between people, talk and touch between people, has therapeutic properties. Communications is important also in that it establishes and is the basis for patient trust, which runs everything. It's the gasoline upon which clinician-patient interactions occur. And without it, it's a lot harder to get anything done. It drives patient engagement. It drives patient compliance or adherence. It drives patient utilization of clinical resources, visits to the emergency room, hospital admissions and readmissions. It drives patient outcomes, something as at the level of A1C or blood pressure levels, even to the higher levels of functioning with respect to things like congestive heart failure. And it drives patient and clinician experiences. It seems as though we spend a lot of time talking about the patient and clinician experience as if it's the most important thing. And while it is perhaps to us as clinicians or providers in that we get paid for it now, from the patient's perspective, the patient experience is not nearly as important as good outcomes and achieving their health objectives. One of my favorite quotes is not mine. It comes from George Bernard Shaw. He basically said, the problem with communications is the illusion that it occurred. And that's appropriate for healthcare as well. Just because our lips move and sound comes out of our mouth doesn't mean that communications occurs. So what are we going to talk about today? There are two ways of approaching the notion of clinician-patient communication gap. There's one, the issue of talking about the symptoms of it. And we all know what the symptoms of these communication gaps are, that we've got now hospitalists inside hospitals who are taking the place of the patient's primary care physician and are or the surgeon, and providing the bulk of care while the patient's hospitalized. And we've all heard the stories about patients not knowing who hospitalists are and what their job is and where's my doctor. Transitions and handoffs, we hear about those all the time, about transitions in care from one stage of care to the next, particularly at the time of hospital discharge, and how important communications are and the kinds of gaps that occur there. We hear about the value of post-discharge hospital instructions given on the day of the last minute of discharge in many cases, when the patient's already got one foot out the door and their mind is certainly somewhere else. We hear a lot of talk about smartphone and technology at the bedside as a way of overcoming communication gaps. The patient's role in safety. There's campaigns out now for patients to take a larger, more active role in asking the clinicians to make sure they wash their hands before they touch the patient. And pianos in the lobby and gourmet meals as examples of ways of overcoming communications gaps. Not my favorite, not particularly relevant, but it's surprising how many people talk about it. But that's not what we're going to talk about today, because you as clinicians know the answers to these better and the challenges to these better than I do. Much of my focus occurs in the ambulatory side of the business, in the doctor's office between clinicians and patients, which is where 85% of care is delivered. Rather, what we're going to talk about are the causes of communications gaps for the amount of time we've got together here. And I've outlined 5 of them. And these are the 5 that we're going to be talking about in the presentation. And I'm not going to read through them all because we're going to go through them individually and discuss them all in some detail. But these are the causes. So these, if you will, drive the symptoms. And so my line of thinking and focusing on these today is that if you understand the causes, or better understand the causes, which we seldom talk about, you're going to be in a much better position to address solutions to it. So let's jump in and get started. Who says we have a communications gap? Well, certainly it's one thing for me to throw it in as a title of a webinar. It certainly generates some interest. But there's no evidence, at least using top-line data coming out of Press Ganey and so many of the other providers of information these days, that in fact we have a problem. Rather, what the data suggests is we don't have a problem. This particular chart is really an amalgam of data from all over the place. But the point is that if you look at any of these satisfaction charts these days, you wouldn't think we do have a problem. The patients are saying that I usually or always get excellent communications from my, in this case, physician, but it could just as easily be nurse, physical therapist, or whatever. Our patients say we are great communicators. This chart was gleaned off of AHRQ's website with respect to some recent data on Hospital Compare. This looked at a hospital. I don't know if we've got anybody from Northwestern in here, but this basically said that 81% of the patients that took the survey, the HiCAP survey through Northwestern, said that their doctors always communicated in an excellent fashion. And then the definition of excellent is off to the right there. And that compared to 81% that said their doctors nationally communicated excellently, and 81% probably in the state of Illinois that said the same thing. So our patients are saying we're all great communicators, 81%, which is just like the last chart. Now the definition for great communication here are derived from HRQ CCAPs this way. Did the clinician treat you with respect? Now remember that as we look at some of these next slides. Did they listen carefully to you? And did they explain things in a way you could understand? Now, my first question that comes to me when I hear these kinds of things is compared to what? Because in the doctor's office, where I spend a great deal of time examining literally the transcripts of conversations between physicians and patients, the issue always comes up, compared to what? If patients have never been exposed to a clinician with excellent communication skills, in this case, patient-centered communication skills, how would they know it when they saw it? Or in the inverse, how could they say someone's good if they've never heard somebody who's really good? And that experience occurred to me not long ago when I had first started the eye surgery, and I ran into my first example of a patient-centered communicator. And it was a surgeon who spent a great deal of time making sure that I understood, that he assessed my values, my interests, what I wanted to get out of the surgery, as if I didn't want to go blind. But the fact that he raised that, discussed it all was amazing to me, because in my many years in the industry, I'd never encountered that. And so I suspect a lot of people in the hospital have never encountered good communications. And therefore, the benchmark's pretty low. Here's one of my favorite quotes from an old professor of mine, Professor Vitas Donavidi, a physician, founder of quality movement in healthcare long before Deming. And here's basically his quote, that patients are in fact overly patient. And they'll put up with all kinds of stuff from their physician, giving them every benefit of the doubt. Why? Because they trust and like them. It's a very personal relationship. But his advice is to folks like us that one can assume that the quality of care is actually worse, and I would say perhaps much worse, than surveys of patient satisfaction would suggest. And that rather than being and saying what they think the clinicians want to hear, which is nice things, the patients would be better served and healthcare would be better served If they were less patient, patients were taught to be less patient, more critical, and more assertive. This was back in '92. A few words about communications. And I'll start and direct your attention to the blue text at the bottom. The communications gap occurs when there's a disconnect between what the clinician intends to say and what the patient thinks they heard. You know, when we talk to one another, when we talk to our spouse, when we talk to patients, other clinicians, everything that we say is filtered through our perceptions of what we said and how we said it, and the tonal quality of our voice and the language we use, and those same filters on the receiver's side. So a patient, for example, comes to their clinician with pre-existing body of knowledge about their condition, what's wrong with them, what caused it, and what may cause it. They've all had previous experiences in their life in doctors' offices and in other healthcare scenarios. They have language and cultural issues. They all have beliefs. We all have beliefs and motivations regarding our health. Belief regarding medications, for example, is a major impediment to patient adherence, simply because so many patients don't believe in taking medications, certainly not as a first course of treatment. We all have different definitions of health. Some people ascribe and aspire to above average health. Some people are quite satisfied with average health. Some people don't believe they can control their health at all, so why bother? So the point is that it's a human function, that there's plenty of room for misconstruence of intentions on the communicator's part and on the receiver's part, and vice versa. And so it's not easy. Now, let's delve into those high communication scores and address that question: who says we got a communications problem? We don't got no stinking communications problem. And the next couple of slides are going to be reflecting data taken from a study at Archives of Internal Medicine in 2010 that looked at the whole issue of communications between clinicians and patients in the hospital. So we'll start right out with the one that everyone's familiar with. Did the patient know the name of the doctor in charge of their hospital care? Certainly with hospitalists, it's a challenge today. And the responses in green here are really what's significant. I highlighted them by drawing a circle around them. 82% of the people responded that they did not, or that they did not know the name of their clinician, the primary clinician in charge of their care. 82%. Now, when asked the same question, 33% of physicians weren't sure that their patients knew their name. You know, and the inverse is 67% of clinicians thought that the patients did know their name. Now, right off the bat, if we're talking about relationships here, that's not a very good way to get started, whether it's a relationship between a patient and a hospitalist or a physician, or a patient and a nurse, or a patient and a physical therapist, or whatever the definition is. The next slide looks at, did hospitalized patients know or reasonably understand their diagnosis? And now this is a question that was asked of the patient and then asked of the physician and clinician, in this case physician as well. 43% of the patients said no, they didn't know and didn't reasonably understand their diagnosis. 77% of physicians thought they did, that patients did understand. 57% of patients said yes, they understood. Now, the 43% is really interesting because you would normally assume and put the blame back on the patient for not asking. Now, but you have to remember that hospitalized patients are not necessarily younger. They're not necessarily terribly proactive. They are wearing a hospital gown, which kind of puts them at a disadvantage. And they may be older, medicated, in pain. But more importantly, who's going to admit they don't understand what's wrong with them? And because people are, at least on the physician office side, so reluctant to challenge their doctor for fear of alienating the doctor, that they're not going to ask the question and not going to tell the doctor, "Doctor, I don't understand you. Please speak English." They simply don't do that in the office, and I suspect they don't do it in the hospital. Did the doctor explain things to you in a comprehensible way? What does that mean? Who's going to understand? Who's ever going to admit that they don't understand what they're being told? Just like the last slide. What's interesting is that clinicians were much more likely to think and agree with the fact that patients really didn't understand what they were being told. Now, which makes you wonder how they could live with themselves when they leave the room, knowing their patient didn't understand what they told them, and knowing that that information is critical to adherence and agreement when it comes to care plans and whatnot once the patient's discharged. This is one of my favorites. Did the doctor tell you that you were prescribed a new medication while hospitalized? 25% of the patients responded no, they didn't know that. 100% of the physicians thought that the patients had a reasonable chance of knowing that. Now, let's look at that same slide now, but broken down by some critical factors about that knowledge. Of the 25% that did know they were prescribed a new medication, of those only 56% of the patients could recall any discussion about how to take the medication in terms of dosage, 68% in terms of schedule, 64% in terms of why they needed the medication in the first place, and 11% on side effects or contraindications. So imagine, 89% of the patients walked out of that exchange, 89% of people knowing they had a new medication, understanding what the side effects were. So now when you start asking about and thinking about patients not doing what they're supposed to do, meaning adherence or compliance, it's interesting that it's hard to comply with something you don't believe in doing if you have a predisposition against taking medication, and or that you don't understand how to take it or why to take it, even if you did agree with medications. And again, remember, patients, particularly in the last day when they were getting ready to get discharged, they're not going to ask, they don't typically ask a lot of questions. They certainly don't ask a lot of questions in the doctor's office, and I'll bet you they don't ask a lot of questions in the hospital room before being discharged. Did the doctor discuss your fears and concerns about being hospitalized with you? 54% of patients said no, they didn't. 98% of physicians said, well, we probably did. Now, this is where we start getting into some of the touchy-feely aspects or patient-centered aspects, if you will, of communications. That as I'm going to address here in just a minute, that the patient's perspective of things is very important. The patient's fears and concerns are very important because that's part of the reason why they're being treated, if there is any elective nature to their procedure at all. But it's also one of those things that clinicians are very loath to want to discuss simply because there's not enough time. I'm just too busy. But if you pursue the conversation with many clinicians, they'll refer to it, at least in the physician's office, as a rabbit hole. You don't want to get down that hole because it's going to take up a lot of time and it's not going to necessarily get you anywhere. The patient may feel better about it, but it won't help me make a diagnosis. So this really kind of takes us into the first of the 5 communications gaps that I want to talk about between clinicians and patients. And remember here we're talking about causes rather than symptoms. So one of the things we discover in the physician's office, and the research on clinician-patient communications in the hospital is no different, is that there's a fundamental lack of agreement between clinicians and patients in many cases on some of the most basic of issues. For example, the patient's diagnosis, or the severity of the disease, or the level and amount and quality of information wanted by the patient, as opposed to the perceived need for information by the clinician. The treatment and care planning, and what constitute acceptable outcomes. So I'm going to just before I get into this, I would just draw your attention to the slide, the right side of the slide, that a professor at UCSF out here in the Bay Area, San Francisco Bay Area, a researcher that I'm familiar with, basically is of the mind that if you're looking for an indicator for high-quality communications between clinicians and patients, you need look no further than the level of agreement between the clinician and patient on issues like the diagnosis and severity of their diagnosis and whatnot. Here's an example. Today there's a lot of emphasis among clinicians with respect to preventing hospital readmissions. Now, one of the one of the diseases or conditions, ambulatory sensitive conditions associated with hospitalizations and rehospitalizations is congestive heart failure or heart failure. And there was a study done recently that by Dr. Sarkar at UCSF that looked at patients within a cardiac clinic that had been hospitalized but were being followed up by their physician in a cardiac clinic. And they looked at, among other things, the congruence between, or the level of agreement between the patient's diagnosis and what they believed, they being the patient. And what they found in this particular study was about 57% of the patients diagnosed with heart failure did not agree with the diagnosis for whatever reason. It may be that they had knowledge of someone else that had been diagnosed, but it turns out was misdiagnosed. Who knows? The point being that something as simple as the diagnosis that we all take for granted, somehow in the patient's filtering of that message interprets it as something else. They may interpret the symptoms of congestive heart failure with, oh, I've always been tired. I've never gotten any exercise, or some other physical manifestation that they could justify. Or it may be that they just don't believe it. Bottom line is they just don't believe it. The severity of their diagnosis is another point where people disagree. Diabetes is a good example. In the physician's office, where much of this research is done, we discovered, for example, that a substantial, up in the range of about 40% of patients who were diagnosed with type 2 diabetes did not agree with their clinician on the diagnosis. And a substantial portion of those then did not agree with the severity of the diagnosis to the extent that they did accept it. In other words, they saw it as something that could be treated and then cured, and oftentimes cited examples of knowledge of other patients, family members, or had other experiences of people who had been diagnosed with type 2 diabetes, but it went away, or that it was just a touch of sugar, and that they lived to the ripe old age of 81. And again, the point here is that people's filters, whether it be their experience, their knowledge, their beliefs, have a tendency of getting in the way and interpreting what clinicians tell them on these basic issues. Another point of interest in research is how much information clinicians feel that patients need. And in many instances, as many as 63% of physicians tend to underestimate the amount of information that patients want with regard to a clinical condition, and that same amount tend to overestimate the amount of information they've given patients. In fact, the point being that they've given them, the clinicians perceive is that they tend to give them more than they have. The patient's perception is that they didn't give me as much as I needed or what I needed. And there's a slide here, we'll speak to that in just a minute. The treatment or care plan, lack of agreement on treatment or care plan. Perhaps the most classic example is in the area of new medications, patients who are prescribed for new medications, whether in the hospital or whether in the physician's office. That's probably one of the biggest areas of disagreement. That if you were to ask patients in the clinician's office their beliefs about taking medications, that the vast majority, over 72% of adults would say, I do not prefer and prefer not to take medications, which really runs contrary to the clinician's perspective, particularly in primary care, that patients just want to be prescribed a pill and walk out and fix it, because that's not what patients want. That may be the perception of the clinician's perception of what patients ultimately are asking them, but clinicians too have their filters and attitudes. But the point here is that if a patient A doesn't believe they have the condition, whether it be congestive heart failure or type 2 diabetes, and B doesn't believe in taking medication as the first line of treatment for a condition, and then all of a sudden the clinician prescribes a medication as a first line of treatment, generally not knowing the bias of the patient against it, what do you think the likelihood is that the patient's going to go out and fill the prescription? And in fact, intentional noncompliance is driven by the fact that the patients don't perceive the need for the medication, or they believe that the side effects and risks of taking the medication outweigh the benefits of taking it. And so they arrive at a conclusion that oftentimes they don't share with their clinician. I'm just not going to take this medication and or not fill the prescription. And then finally, the issue of acceptable outcomes. That's another example of fundamental example of disagreement. That as we'll see on another slide here, that patients, clinicians may shoot for one goal, that is to shrink the size of the tumor, or to shrink or get the patient to the point where their lung cancer can be resected. The patient's acceptable outcome may be, I want the cancer gone, or I want the cough to go away, or I don't want to be in pain anymore, or I want my hair to grow back. And unless there's concurrence or agreement on that, meaning acceptable outcomes, or on any of these others, diagnosis, severity of treatment, or whatnot, it becomes problematic and is an indicator of a communications gap between the patient and clinician. And at the bottom, you see kind of at least in the physician's office, there's a progression that each visit goes through. There is the problem statement, diagnosis, and treatment, and the physician's office visit, much like the hospital rounding, is really all about assessing, doing a quick assessment of the patient, how they're doing, and moving through these issues of problem, diagnosis, and treatment. And the point here is that if there is disagreement at the problem stage, whether it be I don't have that problem or it's not severe if I do have it, it's impossible to successfully proceed on to the diagnostic phase or the treatment phase, because fundamentally the patient doesn't agree with you, doesn't necessarily trust you, and certainly is at higher risk for not doing what you tell them. Now, let's move on to the next communications gap. That too often, and this tends to be the case, I suspect, more in hospitals than the physician's office, although the physician's office is a close second. But the focus is on the disease and not the person with the disease. That we have become so enamored in healthcare today with the notion of technology as a means of getting at the problem, that we don't spend a lot of time understanding the person with the problem. There's a quote out of the Quality of Journal Medicine. Basically, you can read it as well as I do. That it's not uncommon. You have to remember that the whole point of the physician's office visit, and to some extent the hospital rounds, is all about the clinician understanding what the problem is or diagnosing the problem. And we've all heard the quote that patients, particularly in the office, are interrupted within the first 18 seconds. And that's because the clinicians arrive at what they call a differential diagnosis pretty quickly. Some physicians will tell you they can walk in without ever talking to the patient, size the patient up, and arrive at a diagnosis as to what's wrong. One physician actually went so far as to say there's another process that's common in consultations too. It's called the active decision, where clinicians actually stop listening to the patient once they've heard what they think they need to know. Now, imagine being the patient in this scenario, and I suppose we probably can all empathize with it. But it happens. Patients recognize that it happens. The fact that patients feel they're not heard or understood by their clinician, that's not number one as a complaint for, without good reason. But in so doing, meaning in so focusing on the disease, on diagnosing and getting what's wrong with the patient, oftentimes clinicians miss the context of the patient and the context for the illness or the disease or scenario. Because in some cases, I know many of you deal with elective surgical procedures that are not necessarily unanticipated or unpredictable. But clinicians fail to address things like the fears and concerns of the patient in the first place. My greatest fear on my second retinal surgery was based on my experience in the first retinal surgery, where I woke up during the surgery and physically moved on the operating table and ended up with a blind spot in my eye. And the surgeon, I'll never forget the surgeon reminding me, please don't move, you're in surgery. And you can bet your bottom dollar that was a fear I had going into the next surgery. But I mentioned it and got a new surgeon, and the anesthesiologist addressed that issue. But unless you talk about it, or the patient or clinician asks you about it, a lot of times it's not addressed. Our beliefs and attitudes, whether it be about medications, whether it be about the condition that we have, or what we've seen in other patients that have had the condition. Lung cancer is a great example. That the survival rate for stage 4 lung cancer, which is what my wife was diagnosed, is about 6 months. Well, she's going on 10 years. And you have to, you just can't imagine what it's like when she gets together with another newly diagnosed lung cancer patient who believes she's got 6 months to live, and what the impact of her survival, my wife's survival, has on their beliefs and attitudes. It's like a shot in the arm, breath of fresh air. Relevant experiences and expectations, and the patient's hopes, life hopes. What do they aspire to? I'll never forget talking to one patient in a chemotherapy lab as I was waiting for my wife, and the poor fellow probably was 75 and looked very, very, looked like he had cancer. Expressed he's there. I'm here because my family wants me here. If it was up to me, I would just let it run its course. And then I like the cartoon on the right. Doc, please let me know if you want to know why I'm here. I know, it basically speaks to why the clinician knows you're here. The third communications gap cause is what I alluded to earlier, is focus on technology and not the patient. There's an excellent physician at Stanford. His name is Abraham Verghese. He's done some of these TED Talks. And he has spent a lot of time talking about the eye patient, as in iPad and an iPhone kind of eye. And his basic take is that the hospital bedside must be toxic today, because so many clinicians now engage in hospital rounds that take place away from the bedside and away from the patient. And that the focus is rather on the virtual patient, meaning that the focus is on assembling all of the digital data on the patient to arrive at what's wrong with them. And as he goes on to say, that the eye patient is getting fantastic care, but the real patient in the hospital bed wonders where all their caregivers are. And I just underscore the quote at the bottom: what's being lost is the therapeutic value of touch and talk. That, again, there are clinical studies that show that just the ability to talk with somebody about your problem and the therapeutic value of touch have measurable, quantifiable benefits. Now, another take on that technology piece, and I'd start with the cartoon off to the right, with the clinicians looking at the computer and the patient sitting there with arrows through them and the spouse is with them. And the clinician's worried about the cholesterol, and the patient has a different fear, a different concern. And I point this out, and I emphasize this again in the chart where you contrast the need of the patient to feel heard and understood and its impact on trust, in this case patient trust in the clinician. That there's a direct relationship between the extent that they feel heard and understood and the level of trust. Now, obviously, there are other factors of trust, the clinician's skills, clinical skills, and whatnot, but their communication skills are probably what patients are more able to interpret than their diagnostic skills. So the higher the level of feeling heard and listened to, the higher the level of trust, the higher the level of compliance, and the higher level of other good things like outcomes, satisfaction, patient activation, and whatnot. A little bit more on this need to feel heard and understood, and the variance that occurs between patients' concerns and priorities and clinicians. And this is a study that was done in the office. Patients would present in the office, and they would present with the following chief concerns. And when asked what their chief health priorities were, they would identify things like pain, inability to sleep at night, inability to eat, whether their food tasted bad, dizziness, cough. They were reporting things that got in the way of their living a life, their ability to go to work and be productive, their ability to travel to see a grandchild. They were concerned about life-related issues. When asked what the chief priorities of the visit and care of the patient were, clinicians responded, we can't get their hypertension under control. We can't control their A1C. The patient's not taking their medications or not tolerating the medications as prescribed, or we're not able to definitively diagnose what the condition is. So you can see, again, a disconnect there, that the patient wants one thing. They want a normal life, or as close to a normal functioning life as they can get, a quality of life, whereas the clinician's talking about things that to the patient are totally irrelevant. You can see how disconnects can occur. And you can anticipate how the implications of these disconnects on adherence, compliance, and all those good things. Number 4, clinicians and patients think and speak differently. Let's see here. Let's follow that same. Number 4 is closely related to what we've really already talked about. The patients are interested in different sets of outcomes than what clinicians are. Clinicians are interested in biomedical kinds of outcomes, clinical, quantifiable outcomes. Patients are interested in outcomes they can feel and relate to. And I guess it's worth pointing out the patients don't know what they don't know until they're faced with having to do it. And that just giving patients information is not enough. That in so many instances, particularly in the case of heart failure, this particular study looked at the information provided by the clinician, and what the clinician provided to the patient in the way of information was lose weight, go on a diet, eat these kinds of foods, get this much sleep, lose weight. If you gain more, X 5 pounds in a 1 week period of time, call me. So they were interested in conveying to the patient the what to do. Patients, on the other hand, were interested in how do I do this? in other words, the patient said in a separate interview from the clinicians in this research, I understand what the doctor is telling me to lose weight, or I understand what the doctor is telling me to control my A1C, but I don't understand how to do it. And the doctor did not help me come up with strategies to overcome what I perceive as barriers to achieving those goals. So again, a disconnect in terms of the quality and the kind of information exchange. So information is not enough, meaning just the what. Patients need help in understanding the how. And then finally, and here we'll get into questions, the last one is, I'm busy, just do it. And actually, I think I just covered this one. Self-care management instructions for heart failure patients given by the clinician. That it's so easy today to just give information to patients that we think, meets the letter of the clinical guideline: diet, exercise, take medication, stop smoking, monitor your blood pressure. When in reality, patients need help, certainly in the outpatient setting, but I suspect in the inpatient setting too, with overcoming the barriers that they perceive to doing all of these wonderful things. So those are what I consider to be 5, certainly not an exclusive list, but 5 of the top causes for clinician-patient communication gaps in hospitals, but are also found very readily in physicians' offices. I guess this is a good slide that kind of indicates part of the problem with this, I'm busy, just do it, because it implies that they're just, I'm sure most of you are all listening to this saying, oh, this is all well and good, but doctors are busy. Clinicians are busy. Yeah, they are. And this shows you that in the case of medications, just how busy they are. This information came from physicians' offices. This is part of the work that I do. We actually go in and record and deconstruct conversations between patients and clinicians. And in this case, the issue was amount of time spent in seconds spent discussing a new medication that was prescribed. And what you can find is that on average, patients and doctors spend less than 50 seconds talking about a new medication from the standpoint of why they need it, how to take it, when to discontinue it, and whatnot. 50 seconds. And you can then break down on this chart subsets of that kind of, the amount of time spent on various aspects of that medication instruction. So fast forward to the hospital setting where the patient has got one foot out the door and you're trying to give them the discharge instructions, how to take the medication, regardless of whether it's in writing or not. And you see that I'm busy, just do it, really translates into I don't have time, you figure it out. Remember, patients are looking for hows, not whats, and they're looking for that whole general notion of patients are more interested in how much you care than how good you are. However that quote goes, you know what I'm talking about. This particular slide, let's just focus on the little graphic on the right. The patient-centered care occurs when you don't have any of the above gaps, where clinicians and patients are in agreement that the patient is the focus of the disease, not something else, that the patient feels listened to and understood, and that we spend time on the patient and not so much on the concerns and time limitations of the clinicians. What I'm going to do is let's go ahead and jump right into questions. So at this point, I would invite any of you who have particular questions to go ahead and use the question function on the webinar software. And Megan, if at this point, I guess I would ask whether we have any questions.
Great. Thanks, Steve, for that informative presentation. We are going to open it up for questions now. If you have a question, type it into the questions box in your GoToWebinar panel on the right side of your screen. While attendees are submitting questions, I want to remind everyone that today's webinar is sponsored by wellbe.me. The WellBe.me patient guidance system helps fill in clinician-patient communication gaps and reinforce important messages through the entire patient journey of an acute care episode. Smart checklists are delivered just in time as patients progress through their care plans. The information is always there for reference when needed in case preparation or follow-up instructions are forgotten. To request a free demonstration of our software, just respond to the poll. That's going to come up on your screen in just a second. And now I'll check and see if we have any questions here. All right. I have a question asked if we can download the slides, and we will be sending a recording of this presentation and a PDF copy of the slides tomorrow. Steve, what do you tell clinicians and nurses that say they don't have enough time to get down to the hopes and fears and emotional aspects of patient care? Are there key questions they can answer to get to the heart of the point as soon as possible?
There is, and I guess, first of all, you know, this is one of those things where you almost have to make time, because if you stop and think about the inverse, you know, patient-centered care is all about putting the patient at the center of care, not about pianos in the lobbies and gourmet food, or the fact that you think of the patient in the middle of everything. The fact of it is that patient-centered care is where you take the time to ask the patient what they think. You know, how do they feel? What are their fears and concerns? And so, in effect, I think the argument could be made that we're providing a lower level quality of care and a suboptimal patient experience by not taking the time to do that. In the physician's office, what we find is that when they do that, and they in fact enter that data into the patient's record so that from one visit to the next, the clinician is aware of the patient's fears in general, let's say, or their beliefs about medications, then in fact each subsequent visit becomes more productive and in fact shorter. Now, that doesn't translate necessarily and cleanly into the hospital, although it does for hospitals that are now starting to acquire physician practices. But in the hospital, you just have to make the time, either as the nurse at the bedside, and then entering that into the patient's notes, or at least mentioning it to the clinician that the patient is afraid of this or has a fear about this, or that the patient's depressed. Who talks about that? Nobody talks about that. So you know, you just have to make the time for that, Megan.
Okay. We have a comment here from Nancy that says, great discussion of the what regarding communications gaps. Sounds like there's a lot of work to be done to change the culture. What is a successful strategy for getting at the how of eliminating the gap?
Well, the how is kind of implicit in the care gap notion, that the care gaps are occurring because we're all about a clinician or provider-centered care. And one of the immediate strategies for addressing that is for clinicians, providers, to develop patient-centered communication skills, and to become more cognizant of the difference, the differences that exist in a provider-centered or provider-directed approach to providing care and a patient-centered perspective, and then developing concurrent communication skills. So, for example, one of the things we're doing in the physician office side is we're measuring, and we're actually holding a challenge where we're inviting physicians to submit 2 recordings, audio recordings of physician-patient conversations. And then they're being evaluated, and physicians are being shown their communication scores against benchmark best practices for physician-patient communications, and as well as recommendations for just one new patient-centered communication skill they could adopt in the next 12 months. And our logic is that if we could get every hospitalist in an institution to just adopt one new patient-centered communication skill, regardless of what it is, whether it's visit agenda setting or whether it's taking the time to introduce themselves and better understand the patient's beliefs and motivations, that if we could do just one communication, get the clinicians to adopt one new communication skill, patient communication skill, that we'd be a long way down the road to improving outcomes, engagement, patient engagement, satisfaction, experience, and whatnot. So the answer lies in developing and learning patient communication skills. I believe it, that if we were able to achieve that technology aside, it's probably the cheapest, meaning least expensive, high quality, fastest way to get from provider-centered communication to patient-centered communication and the kinds of experiences and outcomes we all want.
Great. Well, Steve, I've given you the controls back. I have a request here from Kathy. If you'd like to see that slide that you skipped right before the last one, she said it looks interesting. If you just want to share your thoughts in the last 5 minutes.
This is the this is really kind of speaks to that issue of the how to get from here to there. That
you want to hit the share your screen button? Sorry, I took it back, so you'll have to. There you go.
Okay. Yeah, I think this is the slide she was referring to. Yeah, this just juxtaposes the the how to get from here to there. The patient-centered approach versus the what the patient needs to do and what the clinician needs to do in a patient-centered environment. And really, patient engagement. Patients are all engaged by the time they're in the hospital. They wouldn't be there otherwise. The question is how engaging are we as clinicians? And 9 times out of 10, what happens in physicians' offices and certainly in the hospital is we spend more time disengaging patients by not being relevant, by not listening to them, by not understanding them. So our challenge as clinicians is to be more engaging, not to engage. Patients are already engaged.
Great. Well, that's all the time we have for today. If anybody has further questions that you didn't have a chance to ask, feel free to email us at info@wellbe.me and we can connect you to Steve. Everybody watch your email tomorrow for a link to the recorded presentation and PDF of the slide set. Thanks, everyone, and have a great day.
Thank you.